Welcome everybody to the Wednesday finance session. The Board of Commissioners has been conducting for a number of years now. Take a look at the ongoing efforts of the county to provide services within the context of the balanced budget. One of the biggest areas of endeavor for the county is our nursing home. And while it does not draw on general fund funds, at this time, hopefully not for any time in the foreseeable future. It is a major service provider to the citizens of the county, and has come up in just about every discussion about trying to generate cost savings and things of that nature. For many years, we've engaged in services of Premier Healthcare Resources, most recently to identify and bring on a new chief administrator in Minnesota. This is it before us today. And as part of the arrangement that we had with Premier conducted a comprehensive operations assessment of the facility, and that's what we're going to hear about today. So without further ado, I'll turn it over to John Bell.
Thank you very much. Congratulations. Operations assessment of Claremont during summer, late summer, and the team member is here. Team members are here if you have any questions. Sherry Hoffman is our clinical associate RN, Ron Deal, operations, and Ed Frigo, fiscal. So they're the ones that are able to answer any questions that we might have. Background on this is the audit review has a focus of we interview staff, department managers, line staff, find out how things are going at the home. We take a look at all the policies and procedures, and we take a look at all the processes and practices that the home has. We go on a tour of the home, we see what's happening, we take data, the data, and then we come out with a report. Our report focuses on 22 different areas within the facility, and our report has 106 recommendations. Now, in our executive summary, we have 18 major recommendations that we made, and I want to focus on those today. Okay. So what I've done here is, so you don't have to go read through the book if you don't want to. You have the book with all 106 recommendations in front of you. Is summarize the ones that we consider to be most important to you. So the first thing that we recommended was to revise the organizational chart to reflect the recommended reporting structure that we would have for you. And the revision should be both at the administrative level and the department level for certain departments within the facility. And so central supply, we're recommending to go from the administrator to the CFO of the facility, Lynette. Check reports to the administrator. We're recommending, because of their counseling duties, that they fall under social services. And then the CFO, who presently reports to Dana here at the county, we've recommended that that report up to the administrator. Second thing that we are recommending is the establishment of a separate admissions department. We talked a little bit about this when we did our 4-month review for you to talk about what we see as a marketing strategy for the future. So we believe that we need to separate admissions from social services, and they both will have a direct reporting relationship to the administrator, and that department should include that admissions department, an admissions director, and a nurse liaison case manager. And we talked a little bit about this a couple of months ago whenever we did our talk to you about the 4 months as the manager. So a little bit more about that nurse liaison case manager. Want that person to be out in the hospital 70% of the time. We want to have a marketing component, as well as to be able to do a clinical assessment on the resident in the hospital and make a decision because that's what our competition is doing. So as much as possible, we want to be able to make that decision quickly. And if the family is available, even start the admissions paperwork at that time. So then we want to reevaluate the admission criteria and determine the cost of transporting dialysis and chemotherapy residents to their outpatient appointments. When we were doing this, as we interviewed personnel, we found out that they were not always accepting dialysis and chemotherapy patients, and we feel that there are opportunities in the reimbursement system on a case-by-case basis to be accepting these types of residents.
Can any of the chemotherapy be delivered on site?
Just our oral, our PO,
Yeah.
and we do take them at times.
So all infusion has to go out? Okay.
And it's the transportation issue that has always been the issue with them denying admission to those types of residents.
The transportation to get them to the chemotherapy site?
It's the cost involved to do it with a stretcher patient. But there are some categories of patients, say for example, a Medicaid patient who has a medical necessity to go on ambulance. That could be billed to the Medicare program under the Part B program, that could get paid. And
Because
so,
not all chemotherapy is delivered in a bed. I mean, you could be ambulatory in the sense of
Correct.
in a wheelchair
Correct.
or walking
correct,
to a chemotherapy site.
correct.
Why couldn't they use our shared ride service?
They have to be, they do at times. Dialysis patients, we do that, and also chemotherapy. It depends on if they're able to medically go by wheelchair. If they are, then we can accept that admission. If they have to go by a stretcher, that's additional cost.
Well, yeah, too. And then the delay in that next run from wherever.
Then they sit
that
for
drop,
hours sometimes.
They may have to sit,
Right.
I mean, I'm thinking Carlisle Regional, they may have to sit in the waiting room there until the bus or whatever transportation comes back for them.
That's what happens with our dialysis patients. If they go by the county transport, there are times they're waiting an hour and a half after their treatment.
What about our number of our EMS units in the county, operate transport vans? I mean, why couldn't they be used or can they be used?
We do at additional cost. We try to take them. We have 2 buses now running for appointments. And we have 2 transportation drivers. And we are now utilizing a second bus to do that, a van to do that here.
Depending on the complexity of the case, I don't know. I would still think that there may be some chemotherapy that would be able to be delivered at the hospital, at the nursing home.
The cost of the chemo agents are rather expensive, but you also have a physician, that's there with the chemotherapy agents. So, again, we take the PO, which is by mouth.
Yeah.
Those agents we can take.
So what is the current admission criteria relative to dialysis or chemotherapy residents right now? We don't.
Ours is that they are able to go in a wheelchair.
Okay.
Yes.
And
Because
we
if
feel
it's
there
a-
are some opportunities for
So you want to
for
look at,
stretcher patients, to look at them on a case-by-case basis.
Okay.
That if the reimbursement is there, that we could take them, would be our opinion.
If they're a Medicaid patient,
Correct.
then we can take them.
okay.
So you deny admissions for someone with a port? You deny admission for someone with a port
A port?
for chemotherapy?
Not necessarily, no.
No.
If they can go by wheelchair,
They could go.
we take
All right.
them. But the other thing is if they're on a skilled stay, if they're on a Medicare stay,
Right.
and we go to an oncologist office, we would have to take the cost of all those medications, which would be very costly, which we would lose money on that patient.
In addition to the transportation.
And on addition to the
And
transportation.
what we're saying is, we just think you need to evaluate these on a case-by-case basis and take a look at some other options that might be reimbursed through the system. All right, we still have a number of collateral materials related to the transitions program. facility brochure, virtual tour of the unit. We're, working on, getting information into the pharmacy, for them to provide that tape for us. So we need to put a final finish on and get that moving again. Then we found that we probably need to, without removing it entirely from the county website, but be able to have the nursing home website stand alone more, so that it's easier when somebody's surfing to be able to come on to the Claremont website. And we feel that eliminate the need for posting the facility rates. And we think that there's more opportunity to expand the area on transitions, because that's the area we want to highlight.
On the website, are there links either way? If I go into the county, I can link to Claremont. If I go into Claremont, can I link back to the county? That's really all you do.
I don't know the answer to that.
I mean, you just need to
Have a
have,
link into Claremont.
I mean, there is no secret that it is the county facility.
No.
So
And it says
if
that
on the
on the
county
website.
website, somebody has the link to Claremont, click on it and move on to Claremont.
Yeah.
If at Claremont, you say, well, damn, who owns this? What's this about? If it's not in that history, then that link should come back to the county government.
Yeah, I don't know that that happens.
And if nothing more than a page on county government,
That's what happens now.
that's what happens now. Well, then you'd be able to expand upon your website as you would want, I would think.
It's
Yeah.
not a
All
question
you're
of,
talking about here is like a domain address, right?
Yeah.
Right.
And that's all you're doing. I mean, and then you link it to the, just have it hooked up to
I
the.
don't think it's a question of address, I think it's a question of having a website dedicated to the nursing home
Yeah.
within our website that fulfills their needs, which may not fit the general sort of format that we use for other departments. Really, where you're going to get most of your traffic from is from search engines anyway.
Yeah.
That's where you optimize the traffic for people who do come to the county website. We do have, it's very easy to find the link to Claremont and to get back. But what I think what you're really talking about is not the physical location, but the features and the emphasis to give it whenever they get there by whatever route, that they can find out the kinds of things we want them to find out.
So a separately designed website is what you're talking about. Because right now, our county website has certain formats. And so we're talking about a separately designed website just for Claremont that would be apart from the county's website, but then you would have a link to the county's website to that.
We probably in all likelihood have the same address that it has now, it just would look different than
Yeah.
we've got.
Yeah.
And we have IT folks in our company that can assist, the county with that whole process. We, set up a number of them for other facilities.
And if you go onto our, what I was getting, the point I was getting at, go on our website, we just redesigned the whole thing in one award. But every department is the same format.
Right.
So I mean, essentially, we would have, potentially a different format here.
Correct. Right. And then, number 7 is, did you have another question?
No, I don't.
Okay. Investigate the potential cost impact of owning certain durable medical equipment. And that would be things like oxygen concentrators. Presently, we rent them for amount per month. The advantage of renting them is that the company provides the maintenance. The downside of that is there's an expense to it. We believe that by owning and either doing the maintenance ourselves, the preventive maintenance, and having somebody come in on an annual basis and look it over, or signing out a contract for just for the maintenance and purchasing it, that the facility, that the company facility could save money that way.
And a liability then falls to however that contract's written.
Well, correct. If you were contracting out the maintenance, then it would fall on them.
Just a quick, sorry to circle back.
Yep.
Just to piggyback on what Commissioner Hertz was saying. The structure of our website, which is just has been redone, clearly it has templates for all the departments, but it also has the ability to be customized within any of the templates is one of the reasons we chose that particular design and that particular approach. So there would always be similarities with the rest of the county website, but you can customize any particular area, both in terms of look and feel, the different features that you load onto it. So it's a very flexible platform that will allow for that to happen. And I don't think anybody's talking about having the nursing home break off
No.
and have a separate
No.
web address that was independent of the counties, even though we're looking at it before.
Okay. Moving on, number 8. And been some discussion with this, some of us spend a lot of time contracting out housekeeping lawn to the dietary departments. We talked about that in the past. Number 9, research and consider the purchase of automated tracking system for new job applications. And we're presently working in that direction.
We're done.
We're there? Okay. So that's been done. And then number 10, evaluate the TV management program. Presently, they are doing initial PPDs, TV tests, 2-step at the time of hire and at the time of admission for a resident. Residents then get every 5 years they get after that, and then employees are getting tested annually thereafter. Those that come in, direct contact with residents. There was a memo that came out from the state that allows you to apply for waivers if you're in a low-risk area and if you follow the protocols by the state and the CDC. So it can save some expense, minimal expense on the PPD test, but a lot of time savings on the cost of giving it. You have to have an RN to give it, and that amount of time that's done with that can be eliminated.
Do we have a question upon returning from vacation that you've traveled anywhere in the world that you would be exposed?
You can be exposed anywhere. I mean, they had a
No,
TV
I'm just saying, in general, a nurse, a staff member at the hospital, goes on a 2-week vacation. Does anyone upon return say, where'd you go? Were you exposed, or have you, been somewhere that, you're asked that question even at the airport to get on a plane, usually, and you see the signs sort of everywhere else that you go to, have you traveled anywhere? And I just wondered if we have in place a question that says to anybody, we don't.
We do not.
So it's either self-reporting or they're sick and they're
Well, we do
doing
not for existing employees.
No.
But if we apply the waiver process here, there's an assessment that's done.
yearly.
And also that one of the questions is have you traveled outside of the country in the last year or so? So that question does come up on the screening program if you decide to use the waiver program to eliminate the need for the PPD in some instances.
It's a yearly screen.
I think it's a valid question.
Sure.
If I were running a hospital
Absolutely.
and I had somebody who wanted to go on
Yeah.
vacation, I'd like to.
Somebody
I
could
know.
have relatives in
You don't
this
have to tell me
area,
where to
they
go.
might be traveling.
But upon your return, I'd like to know if you feel you were in some country or wherever that you may have been exposed to concern. On the job application, going back to Liz, this automated tracking system for new job applicants, countywide or just for the nursing home?
No, we do countywide.
Yeah, I was gonna say, this is just applying this to them.
It already is.
Yeah, and
Yeah,
I think it's working. We're getting out, Cindy just made rehires last week. So.
Okay, so this is,
Yeah.
okay, nothing, all right.
Just on that, number 8, now we received some recommendations on that from you. Are they comprehensive? Are we still waiting on anything with those? You mentioned 9 being complete, but 8 also had.
There's an RFP that's in the process of being developed, or maybe you can
It'll
speak
be,
to that with them.
it'll be going to Keith tomorrow for review.
Right.
Okay.
And then we have to come to the board of commissioners. Board reviews.
And Ashley's aware, we went through all those
That was-
requirements.
Got to be my question. You answered that, thanks.
Well, I can tell you, I'm seriously concerned about this and probably will be voting against it.
Before we even have facts on
I don't think we should be saving costs at the expense of hardworking, dedicated, low-wage county employees.
And just, be advised, we present the options, and then it's up to
I understand.
the county to figure out what they want to, do, and we just have the obligation to present potential savings.
And I also have a concern relative to our oversight with respect to food. I think that, with respect to the food that's served to all of our senior citizens in the nursing home, I don't know that I think it's a smart move, essentially to contract that out, and where we lose accountability and oversight for it.
Just for the record, our management of our food services currently is contracted out to Sedesco. Sedesco manages that and the other areas, but
But you're talking about the employees.
the work is done by the employees.
And what quality assurance is in place?
Well, the same ones that would be in the
Well, assurance would
contract
say
that you
that
sign.
that's in place.
I mean,
Right,
for
but
the
since the
home.
question is
Yeah.
raised as
Yeah.
to one individual can and one individual can't assure
Right,
quality.
the Department of Health comes
You would
in,
hope that-
they attend the quality assurance meetings that the facility has,
Right.
so they fall under all of the
I
standards.
just have some concerns about that.
There's also our monthly resident council, and they tell me straightforward.
Yeah,
I mean,
And I attend every
if the
month.
quality's not there, they'll hear about it loud and clear.
Especially regarding the coffee.
well, and particularly,
I think we
many of the
got
surveys
the
have
bottom
come
of
too. I mean, that is a crucial element of the survey.
But these employees now become employees of,
Sodexo, or
That's right.
or the company
As
that's
opposed to
with
our,
it.
direct oversight.
That's correct.
with respect to those employees.
But Liz answered my question.
Yes.
Thanks.
Moving on to number 11, we see the possibility of contracting out maintenance services, the same with housekeeping, laundry, and dietary. Bring that to your attention, that some of these companies can have automated software systems for work orders and things like that that are advantageous to efficiently working in the home, and they have national contracts for other types of items. Number 12, develop a plan with target states to transition all paper. Yes, ma'am.
Has John looked at, sort of some of those cost savings that we might be looking at yet?
I think that just so, how this is all going, Premier made its recommendations. We don't agree with all of them. This is one in particular we don't agree with, because we have really good facilities department. And John has a lot of, he has, not to say there isn't room for improvement, he has order tracking systems.
I mean, that purchasing, I'm just looking at fuel oil right now, whether that consortium of purchasing power can, be better one way or the other. I don't know that, so that's why I just simply asked John and kind of taking a look at, sort of picking and choosing, maybe some of those would lend themselves better to others and move forward accordingly.
John has not been involved in our process.
Okay. Did you interview or talk with John? Or did you interview and talk with Brad?
John Locke, who's Director of Maintenance at the county, no.
Or Brad King?
Yes,
You did speak with Brad?
absolutely.
Okay.
Yeah.
What would be, how would we determine what those cost savings would be? How would we do that? Right now, the maintenance services that are provided by our
Well, I
current
think that
employees, are we gonna be?
typically when you outsource, the biggest savings is the legacy, is the pension costs, and that's why a lot of homes,
So we're gonna be laying
outsource the
people off,
labor.
John, with this?
Pardon me?
We're gonna be laying people off with this proposal if we're contracting it out?
Well, I don't know, I think that probably any company that would come, that was outsourcing would need people to, man the building. So I would assume that they would be moving them onto their payroll, the same as housekeeping, laundry, and dietary.
That's an assumption.
That would be my assumption.
That's an assumption, okay. We'll have a question about that then, too.
Yep. Okay, and then we took a look at the medical record system, and we're still dealing with a lot of paper, and we have an automated system, electronic medical record, and we think we need to resurrect the efforts to get the record on an electronic system so that we eliminate a lot of the paper and the inefficiencies that are associated with that.
I thought we had, kind of, like the record goes to the doctor's office. That's all.
Not to the doctor's office, but everything
The record
is,
follows the patient though, if the patient goes somewhere.
that's in therapy. That's the therapy we're talking about. He's talking about like the residents' information, and that's all electronic except for some.
Doctor's orders.
Yeah, doctor's orders, but
Yeah.
we still have a hard
Things like
copy.
that still need to be through the electronic
Physician's progress
system.
notes
That
we're
has not
talking
been-
about.
To be clear, we do have a new grow system.
Yes.
And it is called Keen.
Keen system.
Right, I knew, I mean, I was
And
thinking
he-
care tracker and keen confused. I was thinking care tracker, I knew it was a K word, but it was care tracker as opposed to keen.
But not Kronos.
No, I know, and that's another K word. Who knew? So we got these all three going, and I knew we had, because I heard those words before, and it is keen. So, and again, it's a, I thought I understood, sort of follows that patient along, but I thought it was interactive or made available if the patient left the facility, let's say for surgery somewhere. It's not. No. Yet.
None of the
No.
systems are,
Okay.
no.
Should
Not
be.
as is presently configured.
Should be. I mean,
And
that would be good.
Key has changed their name to NTT Data now.
well, there you go.
And so they were acquired,
We went, there was a sale that came up.
just so you know.
Blue light special.
All right,
Okay, well,
fine. Thank you, thank you.
Moving on to number 13, recommend that we hire one additional full-time unit secretary to float. We're doing twice as many admissions as we used to be. A lot of those come in the evening, and there's a high volume of paperwork that needs to be done, and that's the person that is instrumental in getting that person admitted as the charge is being formed. Number 14, implement nurse staff meetings with director of nursing on all three shifts. Presently, what's happening is information is put out to daylight and evening, and then gets passed on by the supervisors to the night shift. We'd like to see meetings on all three shifts. Number 15 is wound care. We do a great job at Claremont in healing up wounds. We have a physician that comes in on a weekly basis doing rounds. We get the wounds, we heal them up. We think that there's a market on the outside. We need to be tooting our horn more than we are to market that service because those are hard to place residents typically.
Now, will we transport to a bariatric facility for wounds?
We try to keep all our wounds here. We have a physician that comes in, he specializes in wounds.
Okay.
Our RN is also specialized in wound care. So
Okay.
every week he comes in 1 to 2 days a week.
All right.
So we can cut the cost, and he's
right.
very
Yeah,
good.
it's also, isn't it like infection management?
Yes, she
More
does.
effective?
Yep.
If it's done on premises.
But I think you're right, I don't think that is an asset that is fully out there in the community that perhaps should be.
Right. It's a niche market that I think we should be taking advantage of. Number 16, right now, your medications, you're on a 30-day cycle. So if you've got a Medicare resident that's in the home and the doctor orders something to that resident, and 2 days later they start having a reaction to it, then in all probability what happens is that you're going to end up throwing that medication away, and then you're going to get billed for a 30-day supply. And then they're going to order a new 30-day supply of medication.
We had talked about that at the pharmacy, and I can remember you mentioning about, cracking open stuff, and it's like, it's open, it's done. Whether there's 1 or 2 that's out, it is gone.
Right.
So, dear friend over the weekend said, back surgery, 60 OxyContin. 2 months worth.
Yeah.
2 months worth, immediately. I mean, went up with it.
So
I'm like,
Road to addiction.
what are we doing?
yeah, we're recommending a 7-day cycle. And in that instance, then if it happens after 2 days, then you're only losing 5 days worth of medication, not 25 days worth of medication.
Does that, to reduce it to that, and I think that makes sense, but does that actually does that cost us more from the pharmacy, or is it still? the
It
same?
should not. They have a prescription fee that they put onto it, but we've been successful in negotiating one prescription fee a month, okay, with many pharmacies. I have to see how the contract is set up here.
And this comes down to one of these things, just do the right thing. Just do the right thing. This is one of these, how much does this cost? Who's in this? But you know what, at the end of the day, do the right thing. Most likely, this patient probably will go back on that, or find some other medication that will cost equally so.
It's the insurance company.
I know, but I'm saying just do the right thing.
And Sherry, correct me, most of our homes that we see are doing like a 7-day supply. That seems to be more the standard, as medications become more and more expensive. Okay. Next is evaluate the cost of installing additional security cameras inside and outside of the building to provide enhanced security. We have a maintenance person on 24 hours a day, and we have a high female-dominated employment area, and so that does provide some amount of security in itself, but it certainly is not the security that in this day and age that maybe we should expect. We think that if we put more security cameras in up and down the halls, we think that it has a twofold benefit for the facility. We have some homes where we have many cameras in the building, and so we're able to enhance the security of the home, but also then we're able to roll back the tape and see where there's times where there's workers' comp injuries, where there's unsafe acts that are being performed in the home that led to the workers' comp injury. And Ron, maybe you can speak to that because you've got a home that's doing that now.
But it's probably a much bigger dollar impact from that respect. There's often cases of employees thinking they were hurt at a certain time at a certain place, and look back at the tape and they were not at that place at that time, nor was there any thing. And that kind of has a domino effect among other employees that they could find out maybe if I tried to claim something that wasn't quite accurate. So another county in Pennsylvania has about half the size of Claremont bed-wise, and has about, I think, over 100 cameras. And their workers' comp cost for the last 20 years, I think, is $500,000
Yeah, it's long.
for the whole 20-year
Well, I guess the
period.
question is, are the cameras monitored, or are they simply recording? Are they actively monitoring?
No one's sitting.
Respond,
No one's
or are they
sitting.
simply recording?
They're recording, but they have monitors. There's monitors, for instance, in the administrator's office, the maintenance director's office. There are monitors in places, nurses' stations, but no one's just sitting there looking at them.
Right, and they're recording simply 24.
So they're digital, so
It's
they're
for record purposes that we can go back and check them. We've already, gone through this with the Department of Health and HIPAA, and they've not found it to be a violation.
But in terms of the security, John, I mean, I would assume that, somebody at the nurse's station is going to be able to view these screens and see who might be walking around where and all that. Is that part of what we're talking? This is not just.
On some cameras, maybe onto the exits, of the building, maybe through the parking lots that they could focus, on the night shift, to make sure that everybody's getting back to their car. But no, not all of the cameras, every area will be monitored by a person.
We have 14 views right now that are monitored.
Okay.
There's 14 camera views.
And where are the monitors?
At first floor, at the switchboard, which is a man from 8 till 9, 8 in the morning till 9 at night. In Brad's office, is there any place else?
Those 3 areas.
Those 3 areas. So there are 14 views.
Okay, what about the head nurses, where they're located?
The first floor nurses
First
station.
floor, okay. So you're able to see all those different views right now?
And down on transitions unit, they also can view the doors, the 2 exit
Yeah,
doors.
Okay.
And then number 18, eliminate the social worker's responsibility to complete the admission paperwork and assign the function to the admissions department. This is the only place that we've seen where the admissions paperwork gets done, after the patient is down on the floor. And it should be done as much as possible before the resident hits the door or at the time they come in. And that should be done by the admissions department. That's the admissions function. Questions for us, Ben?
I would like an opportunity to actually read this.
Fine.
I mean, I see we have a lot of detail in there and explain the position. I thank you for that, but, I didn't get a chance to look at it since I got here, so. But I mean, so I'll take a close look.
Okay.
I don't have anything that really jumps out except some of the initial concerns.
I think that...
What about some of these positions, creating a new department, and are we talking about, what are we talking about in terms of total additional staff or additional expense?
What Raymond and I have talked about is we're looking at one clinical RN case manager that would go out into the community, and that would be the additional staff member. At some point in time, I would see, we're doing a lot of things. We're getting Dr. Lupinacci on board, Dr. Oliverio, Dr. Mira, and all the things that we're doing. I think that the admissions are going to increase based on our past efforts and present efforts here. So I think you're going to need more clerical support for that as well. Now, presently, we have an administrative assistant that's working 32 hours a week, and I think that we can capture an additional 8 hours a week of that person's time to help with the admissions process whenever we're getting 5, 6, 7 admissions, a day, and we need to train her up to do that. But at some point in time, if it goes the way I think it's going to go, you're going to need another half-time or full-time clerical assistant to work in that admissions office. That may not be now, but it may be before the end of the year, 16.
Okay, so you're talking about creating, again, I haven't had a chance to really take a look at it. You're talking about creating an additional admissions department. So how many additional?
Well, not an additional. We're splitting out admissions and social services. We already, right now, the social service director, Tammy Gramley, she is responsible for social services and admissions, and then Helen Schultz is her backup.
Right.
So then what we're talking about is Tammy would move to social services. And then Raymond and I have talked about her being the supervisor of social services, but also taking a caseload down in transitions because the social worker is at the point of almost getting overwhelmed because you've got the number of admissions that are coming in and leaving in very quickly. So as soon as they come in, we're doing a discharge plan on them. And so we think that by giving her part of a caseload down there and then having Helen in the admissions department with a case manager going out to the hospitals, that's the ideal way to set this up.
So you're only talking about
one person, correct. And then at some point in time, increasing clerical support as the admissions go on.
I think too, for the staffing, we've heard this sort of routinely on the late afternoon, early evening,
Correct.
Discharges from a facility coming to us.
Correct.
Not a surprise, kind of like my holiday thing.
Right.
It seems to happen
Yes.
all the time.
Yeah.
So maybe that simple staffing hours, flexibility, I'm looking at Liz, work may be conducive to someone saying, you know what, I can be here at 3 and I can stay till 9 because most likely those hospitals aren't going to be sending someone at 9 o'clock, but they are going to be sending between 4:30, 7, something like that.
That's a prime time. You hit on a good point.
I mean, but it's not something we haven't heard. So that might be a look, again, at the flexibility of staffing.
So
So,
I'm sorry.
okay, so throughout this, though, you've made, on your 106 recommendations.
Correct.
They're all in here.
That's correct.
Okay, you've just highlighted
What
those.
we feel to be the most critical ones for you.
Okay. Not necessarily on survey adjustments, more on administration operation.
Correct, operations.
Okay.
We did.
I think that's important.
Right. We
So
did a
because
mock
we're out on
survey.
the internet right now,
Right.
that these are operational, administrative adjustments, recommendations,
Right.
findings. I think when you say findings, it moves into the language of concerns. And for the finance, and this is what this meeting is, it may be a concern. But I want to certainly convey that on the surveys, both you do your mock surveys,
Right.
and then the Commonwealth comes in. It's a very different kind of findings and recommendations.
Right.
Okay.
And some of the operational things that we've hit on can actually flow over to the,
Exactly.
the
And the impact
care
on
side.
staffing.
Like we get the whole record, into the electronic health record, that certainly can, can avoid mistakes and.
Well, the TV issue, I mean, there's a variety of things here that could impact, if not addressed, or at least looked at, impact what the next survey could be. Okay.
Now, Raymond wanted to talk about the progress that the home has had, and also they divided the recommendations that we made into 3 groups. Now let him talk about
Jim, you
that.
have one more question.
Oh, I'm sorry.
No, that's all right, yeah, on this, I just wanted to ask, so the nurse liaison case manager, you indicated that that individual, whoever it is, going to spend 70% of their time at referring hospitals, is that what?
Correct.
About doing?
Right.
So we would be talking about which hospitals in particular?
Well, you've got the 2 clinical hospitals, you've got the Holy Spirit, and you've got Carlisle. And then remember in our presentation, we talked about expanding that circle, going up to Hershey, the Select Medicals, the LTACs, long-term acute hospitals. So we would expand that area. Going up to the VA hospital in Lebanon, they've been up there, but going up more often, being a presence there. So that's where I see that first.
And you said, and this is not just for transitions then, this is for the rehab, or this is primarily for the rehab?
It's primarily for the rehab because most of the people that they're getting in are going to be covered by the Medicare program.
Okay.
But that's not to say that that they wouldn't do an evaluation of somebody that's not going to be Medicare long-term care.
And you also said that this is what other nursing homes or rehab units are
Absolutely.
doing?
Absolutely. All the for-profits are doing that, and that's our competition in getting residents.
Okay, so they're, in other words, they're right there at the hospitals and signing up.
It's the standard.
Okay. All right. Okay.
And this is part of, in our original model, we assumed, we had a threshold of X in order to make the rehab unit a viable operation, given that the length of stay turned out to be shorter than our original assumptions. Clearly, the number of referrals needs to increase, and it won't happen by wishing and hoping. You have to go out there and go on business.
Questions? Raymond?
Yes. Okay, I wanted to thank John, and of course, Premier for the wonderful extensive report. I've read every page. Definitely a very involved reading. What we like to talk about now, based on what we looked at, and what we're going to use is also the executive summary, and I also have it numbered if that helps, for you to go through in terms of 5 things that we consider to be implementing very soon if they haven't been done already. 5 good things to consider for the near future, and 5 things that are not a priority, not a basic priority. One of those 5 things, just to let you know, are actually in process, but we wanted to focus on what's really in priority. Okay, so the first thing that we really feel, based on the report, is separate admissions department that includes the nurse liaison, which is what we talked about. And that's actually in process in the sense that we're going to be having weekly meetings starting on the 9th to talk about the process of getting there in terms of what's going to happen. And in a sense, establishing a timeline of where we are and where we want to be by the beginning of next year for our nurse liaison and the admissions department to make sure it flows pretty well. And I have a committee, admissions committee exactly, that we're going to be discussing this with to make sure it does proceed. Next important thing to consider is to revise the organizational chart to reflect operating structure. We found that the existing operational chart and also Premier's weren't exactly 100% where we are, but we have, with the help of Liz Bouche, developed, and of course Lynette, the actual organizational chart that reflects who we cover and who we're in charge of. Finished promotional materials, including virtual tour of unit. That is in process and actually almost at the end. Helen Schultz has been working closely with county communications to get that done. Next one would be evaluate outsourcing of dietary, housekeeping, and laundry. We have that in process. RFP is prepared as discussed. And the automatic tracking system for new job applications, that's already done, and that is one of our first 5 important things that have to be either implemented soon or already in process or here. Next is our 5 good things to consider in the future. Definitely, we want to consider
John,
marketing.
excuse me, do we have a copy of what your,
Their number, I just did it. You did, 5 is number 9, 8 is number 4.
okay, 8?
I'm sorry, you know what I'm going to do? I'll give you the
Number
numbers.
5 is number 3.
I have 1, 2, 5,
Number 2
8
is number
so far.
4.
Yeah, 2, 1, 5, 8, and 9 are our top 5.
Right.
Okay. Now, what I'll do is I'll give you the number with.
Okay.
Okay.
Yeah.
Good things to consider in the future. Number 15, consider marketing the wound care program. That is very important, and that's something we're definitely going to be heading in that direction, since we are, in a sense, best practice with regards to that. That's something we definitely have to do, totally agree with that. Next would be number 6. Move Claremont website off county's website, but still have a link. And in a sense of what we talked about. Then would be number 17, evaluate costs for additional security cameras. You know, because we are concerned about the security of our staff as well as our residents and families. Then number 4, transporting of dialysis and chemotherapy. That is in process for us, especially with regards to dialysis. And also, we do look at chemotherapy on a case-by-case basis. And then, of course, number 10, which would be TB testing program change, which we discussed as well. We're in agreement with the things we need to do in the near future. The things we don't see as a priority are number 12, transition physicians' records to fully electronic, because at that point, you know, it's definitely going to be happening with Keene's system, but it's not something that's on the top of what we need to be doing, but it is happening in that respect. Next would be number 7, potential cost savings of durable medical equipment. Again, you know, with that, we do understand with renting versus owning, but in a lot of situations, if we have our short-term rehab residents, you know, the short time that we rent, we just ensure that the equipment gets back. You know, we don't necessarily have to deal with that cost, only in the sense of long-term. And I think we have a few, but not a lot.
I guess the question is, on the DMEs, we've seen some come that have been patient-specific. Then others may be universally used.
Right.
So I think you have to weigh the.
This is the
I mean,
universal.
wheelchair is $17,000.
That's not what we're talking
No.
about.
Right,
universal.
but it's still DMEs.
Yes, that's
Yes.
correct.
So I guess-
Durable medical equipment can be,
So I guess the question is it, you know, sort of patient-specific, as we've kind of seen before, or that universal piece of equipment that could be used? And that's why I asked about the liability
Right.
using that equipment. You know, is it cleaned properly? Or are you gonna make the headline that 3,000 patients now may have infection, blah, blah, blah?
Yeah, we very.
You do, you do,
And
respectfully
also
so.
lock out, tag out of the equipment.
Yeah,
Something
so,
goes wrong, you know, you have to make sure it's properly
Right.
taken off. the
yeah,
unit.
so that, okay, good, thanks.
Next would be cost savings from outsourcing maintenance.
Okay.
What's the number on that?
Oh, I'm sorry, number 11, excuse me.
Brandon, I'm sorry, I called you John before.
Oh, that's right. Number 11. Then number 16, 7-day supply of medicines for short term. That's actually in process. That's something that we are following up on. It's not a tremendous priority for us, but it is being done. And then rehab manager and daily morning meeting, clinical meeting, that's number 4.
and that's in the back part of the
Right.
That one's not in the executive summary.
Oh, I'm sorry.
Right, that one doesn't have an executive summary.
Excuse me. Okay, because the rehab manager is always involved in our Medicare meetings, you know, they're always talking, they have a pre-meeting way before stand-up, so, you know, that's kind of redundant to have them involved. And that is our recommendations.
Good. Questions?
Any questions or anything?
Comments?
I think we appreciate Mayor's efforts to collect this information, and we had a productive collaboration on reviewing it. We didn't necessarily see eye to eye on every issue, but I think, you know, some of the things are right on target. And other things are, and particularly around the issue, how do we get to the rehab unit to realize its potential? And generally those referrals, which requires not only comprehensive market program, but also it has sort of a domino effect on the rest of the operation. And I've always thought that you would come to work one day and find that Helen had just decided to go make candles in the desert because I don't think it's been pulled in too many directions at once.
I think if we take these in also association with this, maybe the next review team, see where some have moved off the table, maybe have moved on the table, what's achievable in a short term and long, you know, sort of the numbers are, you know, this will go in immediately, what can be done sort of cost effectively immediately, no cost in some case, and then what will require maybe additional, you know, dollars or whatever. So.
Yeah, the website, that shouldn't cost that much, right?
And we have somebody in our company that would be happy to assist your folks with that as well.
And we probably also have resources on staff to do that. I think, you know, the key thing is the design. What do you want, what are the features, what do you want to highlight? Are you going to, I think one of the strengths of our new system is the ease of navigation. And how would you make sure that if we customized or further enhanced the sub-pages for the nursing homes, how to make sure we maintain that ease of navigation.
Right.
But, I mean, you can see, you know, with the kind of, you look at our web, the main page, you land on the main page, we have, you know, the slideshow that goes on. There's every reason to think that something like that would be very beneficial to what you're trying to do. If you wanted to highlight the wound care, if you want to highlight the rehab center, the dementia center, what have you, the virtual tour, these are all things that the casual user should have absolutely no trouble finding, and in fact be presented within the first 15 seconds that they're in on that site.
Right.
Not, if they go there and they don't find what they're looking for, they're gone.
Yeah.
I was just thinking, I mean, one of the things that you mentioned, John, before, and I think that one of the things we really want to promote is we're, you know, the only location for 7-day a week, no rehab care.
Right.
Like a 5-day a week.
Right.
Rehab care.
Absolutely. Big selling point.
Because I know, I was wondering if that, I don't remember seeing
I don't think so.
the 7-day a week we have on the website. That's pretty important. You know, I mean, realistically, I think we're all headed in the right direction in terms of what we want for the nursing home. We want to see it succeed. I think, you know, in terms of that, the website's very important, but, you know, we have to also get our star rating back up because that's what they look at first. Yeah. Because I've been through that thing where I was a 3 and we went to a 5, and people came out of nowhere and said, oh, I hate it, highly recommend it. So that's the first process.
It's like all those websites.
It's like a hotel. Yeah, it is, exactly, it's like a hotel.
It's like
You
kayak.
gotta open the door.
Or Yelp.
Yeah.
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 What are you gonna do, go to a 1-star restaurant? Nobody's gonna go to a 1-star
I know.
restaurant. Or they're gonna hear one complaint and go, I'm not going there. And they might be very good. Might have very good ratings.
because it was a snapshot in time, at
Yeah,
that moment.
exactly.
And it is just that. Moment. It is not performance over a period of time. Nobody takes the time to look at that.
Yeah.
Not that snapshot. This is
Oh,
good,
I do,
this
I
is
mean,
bad.
the problem with me is I read every review and then make an assumption. They could be there for hours.
Well,
But it's important.
anything else for today? Thank you.
Thank you very much.
Thank you so much.
Thanks very much.